once an individual is able to enroll or be enrolled in a health insurance plan, for example, being able to then have a provider that's, automatically assigned, given where you're at. We know that there's not necessarily enough providers. So being able to have that initial assignment might reduce the burden of an individual having to navigate the healthcare system when they're not familiar with that. So that could help with individuals accessing their provider more readily than having to do it on their own and kind of navigating it through, a computer, or making sure that they even have, access to broadband or a computer to begin with, and being able to have the literacy to use technology might be reduced in terms of a barrier.
Welcome to the Health Disparities podcast from Women is Life. I'm Dr. Ramon Jimenez, a founding board member of Women is Life and also treasurer of this nonprofit foundation. For too many people in the United States, healthcare is unaffordable and not accessible. Even patients who have healthcare insurance can be confronted with barriers that keep them from accessing the healthcare that they need. And when you look at the data, disparities are rampant. Healthcare access and outcomes are worse for people of color and other marginalized groups. A new report from the PAN Foundation breaks down these disparities and highlights next steps for creating more equitable access to care. As it states on their website, quotes, "We help underinsured people with life-threatening, chronic, or rare diseases get the medications and treatments they need by assisting with their out-of-pocket costs and advocating for improved access and affordability." To learn more, I'm joined now by PAN Foundation's health policy expert and chief mission officer, Amy Niles. Amy, welcome to the Health Disparities podcast.
Thank you so much. I'm glad to be here.
You're welcome. In addition, I'm also joined by Dr. Adriana Nava, president of the National Association of Hispanic Nurses, which is an advocate for increasing access to care for underserved populations. NAHN, or NAHN, works to help people from Hispanic communities have access to affordable, equitable health care. Adriana, welcome to you as well.
Thank you so much.
So, for particulars and more resource, you'll find at the end of the footnotes of this podcast resource materials you can go to about PAN Foundation's work. So, Amy, I had some questions. Let's talk about the new report. The PAN Foundation worked with the Harris Poll to survey about 2,500 adults, which is diverse populations across the country. What was your aim? What were you hoping to find out?
Yeah, thanks for your interest in the State of Patient Access report. This was a critical initiative under the auspices of PAN's newly developed Center for Patient Research. And our goal with the project was really to understand the challenges that adults living with chronic conditions every single day face accessing the care they need. More importantly, our goal was to understand how what disparities exist, and there were some significant disparities between various groups and communities. So you're right, we surveyed 2,500 individuals living with chronic conditions. On average, individuals had about 4 chronic conditions, and we ensured that our population was diverse so that we would be able to compare findings. And just a little bit about the report, we created a scorecard which aggregated patients' responses to questions in 5 different areas using a pretty rigorous methodology. And the questions were grouped into 5 categories: overall access to care, relationship with healthcare providers, affordability of prescription medications, access to treatment through healthcare plans, and financial toxicity. And when we look at the overall study, patients across the country gave access to care a grade C, which in my opinion is not very good wasn't terribly surprising either. But when we dove into the various groups and communities that we surveyed, we found a lot of disparities, and those grades often were much lower or even failing grades.
Yes, I was surprised also to see in your report. It was very clearly demonstrated in that graphic that you had that nearly 1/3 of the people experienced a barrier when it comes to receiving health care. What kinds of health care disparities did you find when it comes to overall access?
There were a lot of them, and I'll go through some of them, but your listeners can read the report in a whole lot more detail. But yes, there were challenges in terms of accessing the care patients needed. This could be in terms of getting appointments or being able to afford their treatments, or restrictions that were put on them by their healthcare plans. We found that overall, patients do trust their healthcare providers, but 1 in 3 indicated that there were certain circumstances that didn't create an optimal effective partnership. And so they thought that, for example, that providers often don't take their concerns seriously, or they're critical of their lifestyle habits. One of our dimensions, which was access to through healthcare plans, got the worst grades. And overall, adults rated this dimension D-. Certain groups, like Hispanic patients, gave this dimension a failing grade. And we hear this all the time. There are tremendous healthcare plan challenges. Medications are not covered on formularies, high out-of-pocket costs, high deductibles, and prior auth challenges, getting the prior authorizations before proceeding. So a lot of disparities, and there's no shortage of issues faced by adults throughout the country accessing the care that's been prescribed by their healthcare professionals and care that they need.
Yes, as a treating orthopedic surgeon, when I would write prescriptions for certain patients, I would just be mindful of the fact that they may go out and not even have the prescription filled because of a lack of resources to do so, or they may get the prescription filled somewhat, but then take half the dose in order to let it make it last longer, and things like that, which directly impact the effects of treatment and leads to more disparities, if you would, just by itself.
And it's exactly what we found in the report. That dimension that looked at prescription medications, overall, adults gave it a B-, but Hispanic patients, those identifying as LGBTQ, gave it much lower grades. And some of the statistics were really disturbing to me, but again, not terribly surprising. 1 in 5 adults said that their medications were just not affordable. Overwhelming majority of patients who thought that took some action. And those actions were 1 in 2 decided not to fill their prescription. That's a high percentage. A third chose to go back to their healthcare provider to find a more affordable treatment. A third decided to ration their treatment, make the prescription last longer. And a quarter simply chose, not to just stop taking their medication. And all these actions, as reported by the adults, really had significant impact on their physical and mental health.
Sure. Some of our listeners may wonder about the fact that they could see that Hispanics, Native Americans may come from underserved areas, underserved communities, etc. But why does LGBTQ patients fall in that category?
I think they feel disenfranchised, and we saw it in the questions relating to effective partnerships with their healthcare providers. There are many reasons, and I'm probably not going to do this question justice, but I do feel that people in the LGBTQ community are concerned about the conversations that they're having with their healthcare providers, that they may not be taken seriously, or they're being judged in terms of their lifestyle habits.
Yeah, another potential reason it may be true or not is that maybe their partners are not recognized in drug coverage and in healthcare coverage like the traditional heterosexuals.
Mm-hmm.
So, Adriana, the National Association of Hispanic Nurses advocated for improvements to the healthcare system and access to care. Did any of the findings that have been articulated so far surprise you, and why or why not?
Yes, when I first read the report, I wasn't too surprised that there was dissatisfaction generally with accessibility and paying for medications. It was interesting that the Latino population did see and did, note that there were additional challenges. But I think, being um, focused on underserved populations, sometimes we don't give as much attention to individuals that are not necessarily those at the greatest need. But yet, this report highlighted that even individuals who are insured are still having challenges paying for prescriptions. And how do we reach and address the needs of individuals that are also not necessarily always in the limelight of getting some advocacy, but also making sure that we address their needs as well from a health insurance or even access standpoint. And one of the things I also thought was really interesting in this report was individuals feeling that some aspect of their identity would lead to less quality care, or not being able to find that high quality care that they deserve. So even from a workforce standpoint, how do we better integrate trust and build that trust so individuals feel safe to be their true authentic selves and come to a place where they're going to receive high quality care?
Great. And it's easy to get bogged down in the numbers and forget that behind all these numbers are real people who cannot access healthcare and who suffer because of that. Are there any stories of patients that you can share about what this looks like on a very personal level in the Hispanic community?
Sure. So, with our organization, I just want to provide a little bit of context. So, we have over 40 chapters across the country within 24 states. And a lot of the work that our nurses do is they're volunteers within their community. So, they're often hosting health fairs, providing information that's bilingual to patients that don't necessarily have access to care or may not have access to resources in their preferred language, such as in Spanish. So, oftentimes we hear about individuals not necessarily trusting going to a healthcare provider. So that might be one reason, but also the fact that a lot of them don't have access to care, especially if they're within a state that did not expand Medicaid. So then they're left in the coverage gap. So as an organization, we've been really focused on elevating the needs of increasing access to care, especially Medicaid expansion, through our Hispanic Health Policy Summit that we hold once a year. So that has been some of the work that we've been doing. But even within our own membership, we do have nurses and students who are DACA recipients. So the recent move to have DACA individuals eligible for health insurance through an exchange was really helpful for this population, especially as they continue their education. Making sure that they have access to care is really important.
Oh, great. Educate me a little bit more. As you were speaking, it made me wonder, does the National Association of Hispanic Nurses, do you collaborate with community healthcare workers, promotoras?
So we don't have a formal national partnership at this point, but that's a very great idea for us to get in contact with. But at the local chapter level, our chapter leaders do a great job working locally with different partners to ensure that they're able to, share resources and expand their outreach to the Latino community, but even, others in their community that they serve.
Great. Just as a note, I know that Texas is very much involved with formatoras, and there's at San Francisco State College, there's I think it's a year course that they take for credentialing to be CHW or promotoras, which was a lot of interest to me when I saw it. So, Amy, can we talk about why it's important to collect this kind of data and follow it year after year In other words, I understand the first report is going to serve like a baseline.
Exactly. It's while the data was not wonderful data to hear, I think regardless, it's good to have this data because it does serve as a baseline. For us at PAN, and I'm sure it's the same for NON and other groups, it really provides us with a roadmap, if you will, for the kinds of policy solutions we advocate for, and even the education that may be needed by patients and providers. And it also encourages, I think, all of us to form those kinds of partnerships that you were just talking about, to better serve our patients. So we are going to conduct this survey year over year. We're going out this August with our second poll. And, really the goal is, are we moving the needle? Are we making a difference to improve access to care, or are we not? And what can we do about it? And that's really the goal of this report.
Great. Yeah, we need to find out if we're just spinning our wheels, right?
Hopefully not. Hopefully not.
Exactly. Adriana, it can be very discouraging to learn about these kinds of health disparities, especially when they seem to be persistent. So, talking about solutions, what does it take to address these health disparities, in particular for the Hispanic community?
So what we've really been focused on at NON has been looking at increasing the pipeline of Latinos interested in the healthcare workforce and careers in the healthcare workforce, and even seeking leadership roles within their local community in order to be in places where they can make decisions about what's going on in the affairs of their local community, but also achieving higher levels of leadership as well within their organizations and even at the state and national level. So we've been able to provide scholarships and mentoring to students who are interested in nursing and even nurses themselves who are interested in that leadership development. We've also been focusing on making sure that we're getting a better, doing a better job of translating some of our health documents. So any partners that we have when we're out in the community, making sure information is available in English and in Spanish. And we've also been focused on addressing some of the misinformation that is really targeted towards Latinos. We saw during the COVID pandemic, a lot of the information in Spanish tended to be not accurate, and especially many Latinos tend to take a lot of information in through social media. So making sure that as an organization, we're able to meet our Latino population where they're at in terms of where they're getting their information, but making sure that it's accurate and represented by nursing professionals, which we know that nurses are a highly trusted profession within the US. So making sure that we can leverage that to make sure that information is accurate and our community has a place where that they can go for trusted information.
Great. So this is directed to the Ann sisters. And when I say that, I mean Amy Niles and Adriana Nava. So, and both of you. So in light of these findings, what's your message to policymakers? And are you listening to Amy when and if you go to Congress, what changes do you feel are necessary at the policy level to move the needle on these health disparities?
First and foremost is making sure that any policy that is put forth or a piece of legislation is truly patient-centric and is designed with the patients in mind. And I think all too often we find that the patient voice is simply not heard, or patients are not, at the table as pieces of legislation are put together. So I think that is critically important. One of the reasons why PAN has an annual Hill Day and NON has their Hill Day, to make sure we can bring these important voices to our elected officials. So that's at the very broad level. I think there are specific things that kind of came out through the State of Patient Access report that will help many patients, regardless of groups and communities. One is, we heard loud and clear through the report concerns around prior authorization and the tremendous delays in treatment that causes for everyone. And we know that Congress is very interested and intends to introduce legislation that will streamline the prior authorization process. That will be a step in the right direction. Secondly, we know come January 1st, there are important Medicare reforms that will significantly lower out-of-pocket costs for prescription medications for people on Medicare. That's great. But what about everyone else, especially people, on the exchanges, people who are commercially insured? They need that kind of relief as well. And so we're hoping that Congress can move in that direction. We know that. Did you have a question?
Now I was going to make a comment is that
Okay.
do you find that it's necessary sometimes to educate, clarify either the congresspersons or their health policy advocate in their office that the real difference between diversity and disparities. In other words, I think they get hung up sometimes, especially in this anti-DEI attitude or notions that are going on now, that what are disparities, and do we need to? Do you find that it's necessary to clarify that?
I find that it's necessary to have conversations just to introduce the notion to them and to discuss the disparities. When I'm on the Hill, I'm mostly speaking with staffers and not their elected officials. And oftentimes the staffers themselves need a lot of education. This is not a criticism. They just need a lot of education around the particular health issues. And often we simply don't get into the very important conversations around diversity and disparity, which is unfortunate. It needs to happen more. Adriana, I don't know if you have anything to add.
Sure, and I think the challenge historically has also been, and I know Amy, you touched on this earlier about the need to collect accurate data. And for a long time, we weren't able to necessarily, because it wasn't reported or we didn't have the infrastructure in place to be able to collect the data at, for example, the level of race and ethnicity. And now with the recent changes in OMB to, categorizing Hispanics, for example, under race, that should help with collecting more accurate data, but there might be still opportunities for improving the way we identify specific groups or who's missing from that list. And then what do we do with that data once we're able to capture it? And then linking it back to like our quality indicators that we have in place as well.
I can only second what you're both saying, and you particularly, Amy, about when you visit Congress, is that even though I knew 4 or 5 of our Congress people here in California on a first name basis, on a personal basis also, I found that their staff, even their health care staff, really needed and really welcomed education, so they could then be the conduit to educate their member, if you would. And so I think that that's very important work when we go visit Congress. Amy, not Amy, I'm sorry, Adriana, on the ground level, at the clinical level, what kinds of changes are need to happen?
So we've noticed more recently now, because there's been more quality measures that are focused on addressing the social determinants of health. We've been noticing a lot more systems and healthcare providers asking patients about what their social needs are, because we know that your health is impacted by where you live, where your climate that you're surrounded by, all these non-clinical factors that impact your health. So being able to accurately capture that information and then link individuals to resources in their local community in a timely manner is really important. And we've been seeing a move from the systems and even from healthcare providers in addressing individuals' social determinants of health.
Great. Now, Gianna, in the Hispanic community that remains, uninsured, there's been some talk about insurance enrollment making it automated. What difference would that make?
So there's already a lot of challenges to, even just knowing where to go. So once an individual is able to enroll or be enrolled in a health insurance plan, for example, being able to then have a provider that's, automatically assigned, given where you're at. We know that there's not necessarily enough providers. So being able to have that initial assignment might reduce the burden of an individual having to navigate the healthcare system when they're not familiar with that. So that could help with individuals accessing their provider more readily than having to do it on their own and kind of navigating it through, a computer, or making sure that they even have, access to broadband or a computer to begin with, and being able to have the literacy to use technology might be reduced in terms of a barrier if we're able to automatically enroll individuals.
Great, great. So both Amy and Adriana, this will be the last, sort of the last question. Uh, So are there any bright spots that you see when it comes to addressing health disparities in communities of color and other underserved groups? Are there clinics or hospitals that have started to do some of the things you mentioned, like screening for social determinants? And on the other hand, are there any states that are considering automated enrollment into insurance plans? So, Amy, would you like to go first?
I don't want to end on a negative note, because there were lots of not so great data in the state of patient access. But if I step back and think broadly about where we've come, I do think that there's some bright spots. I think overall the patient voice is being elevated. I think all of us in the patient advocacy community, the professional community, are working really hard to make sure the patients are seen, heard, listened to, and that they feel empowered. We're doing all we can at the federal and state level on policy to improve access. I think while we have a long way to go, there's tremendous interest in lowering prescription drug costs in this country. So again, many more steps to be taken, but Congress has taken some important steps over the last few years. I think there's growing interest in diversity in clinical trials. We haven't talked about that, but again, here too, a long way to go to build the trust within diverse communities, but it's really important, and I think all of us are committed to seeing that happen. Adriana talked about social drivers of health. I think we're doing a better job, but yet there's so much more to do, and I think it's difficult for the healthcare provider community, especially physicians, to find the time within a 10-minute visit to ask all the right questions of the patients. So we have to find ways to do a better job of supporting those patients. And then finally, I would say that I think we're all trying to invest more in community work. You talked about community health workers earlier, but health is at the local level. And I know hospitals, I know NON, and even the PAN Foundation, we are investing in communities to learn more, to listen to the community, to understand why they're having challenges accessing the care they need, and to figure out local solutions. We've been in Metro Atlanta. We're moving to Dallas soon, and hope to move to other communities as well.
Great. Let me just comment briefly on what you just said, Amy, and I really appreciate your remarks. Is that the American Association of Latino Orthopedic Surgeons, we're really pushing to try to get more orthopedic surgeons who are racially or ethnic concordant with the exploding Latino population, if you would. But there is a big disparity gap. There's only at best 6% of orthopedic surgeons, of 33,000 orthopedic surgeons, are Hispanic Latino, where the population is up to about 20%, and will be at 25% by another 10 years for sure. And so what we decided to do is to really have to include uh, those physicians, primary care providers, orthopedic surgeons, et cetera, who who are not Latino to and who serve Hispanic Latino communities, so that they present a venue in their office, if you would, that is Hispanic Latino friendly. I mean, that doesn't mean you got to have serapes and sombreros in your waiting room, but it means that if you have a receptionist who is bilingual, a medical assistant or whatever, um, patients will really accept that and feel more comfortable in being able to explain what's going on with them, because we all know as providers that the history you get from the patient leads to a better diagnosis and better treatment. So thank you for allowing me to go on my little harangue there for a minute or so. Adriana,
Yeah, no, I think that really resonated with me, Dr. Jimenez, especially, talking about the need to increase the number of Latino providers. And even for nursing as a profession, we have 5 million nurses and less than 10% are Hispanic. So we've been working a lot to increase that pipeline. And one of the bright spots that I would like to go back to is that we have seen that over the course of time that Latino Americans are continuing to increase the number of degrees that they are obtaining. So I think that's helpful in terms of their family being able to make better, healthier choices or health behaviors for their families. But even professionally, we've noticed when we focus on self-advocacy of not only ourselves and our family, but of those in our community, we tend to be able to increase our efforts to reduce health disparities. And even at the National Association of Hispanic Nurses, we've been really focused on being advocates for our community. And with this new lens that we've been bringing to our work, we've noticed a 53% increase in our membership over the last 3 years. So we've noticed that we're, gaining a voice professionally as nurses that are Latinos, but also more visibility in the larger community to address some of the pressing issues that our Latino families face every day. So happy to share that.
great. I hold a surgical skills session for high schoolers. Uh, I happen to chair a board that owns 3 charter high schools in California. In East San Jose, 95% are Hispanic Latinos. And we encourage them, we hold the surgical skills so that not so they can become orthopedic surgeons, but just to kind of stimulate their juices to, you know, to enter the health sciences as physical therapists, assistants, medical assistants, uh, nursing, community healthcare workers, et cetera. We really need that if we're going to provide the best care for our patients. Just one last question. Could either of you name any states that are considering automated enrollment into insurance plans? Right offhand.
I'm not familiar, but I do know this is maybe somewhat related when it comes to the Extra Help program, which is it's a federal program for low income individuals. You are auto enrolled into that program, which means you'll probably pay no out of pocket costs for your prescription medications or virtually none, but you're auto enrolled if you have both Medicare and Medicaid. So it's a little bit different, but I agree that sometimes having that auto enrollment opportunity goes a long way to improving access to care.
Yeah, I have to do some research regarding our governor is pretty liberal, and here in California we do. I just had not heard that term automated enrollment as it applies to the insurance plans here, but I think it's something like that, but I don't know for sure. So with that, let me start in closing to say that you can learn more about PAN Foundation State of Patient Access Report at the link, which is at the end of our show notes. And so coming to the end of another episode of the Health Disparities Podcast from Women is Life, I'd like to thank my guest, Amy Niles and Adriana Nava, thank you very, very much for being with us. You really have educated us, elucidated some issues for us, and hopefully moved the needle. So if you like to hear, if you like what you hear, be sure to subscribe wherever you get your podcasts and take a moment to leave us a rating. It does make a difference. And mark your calendar for our upcoming annual Summit of Movement is Life. This year, we have a change of venue from Washington, D.C. to Atlanta, Georgia. And so on Thursday, November 14th and Friday, November 15th, we'll be at the Whitley Hotel, which is in the Buckhead area of Atlanta. Please go to our website for more information and to register. I'm Dr. Ramon Jimenez, and until next time, be safe and be well.